Hi, this is a fabulous honor, and I thank you for it. And thanks for all the lovely things you said, and thank you to all the wonderful people here supporting us from the city and from the province and from the faculty. I'm going to try to talk tonight about where a faculty of medicine fits into the issues of global health and how it can be a global citizen. And I'm going to ask you to forgive me in advance for A, getting carried away, and B, assuming that I need to preach, because I know I'm preaching to the converted. But I'd like to make a couple of definitions. Number one is global citizenship, and I want to mention the term just because it's relatively new, and I don't think that we've used it much. It's complex, and it's the politics and the economics, and it's recognizing that we are part of this bigger world and somehow have to figure out how to connect to it. And it's making those links, and I think actually you don't need to go anywhere to do it. I think you can do it from right here in a thought process and in your actions and interests and commitments. So I think it's fairly simple. It's seeing self in others. And the second definition I'd like to make is health, the global health definition. And there are many complicated definitions about diseases crossing boundaries and travelers' exposure and immigrant diseases brought into the country. But in fact, the definition that has been used in this program and in our convictions over the past decade has been that global health is health of the poor. And if you start there, you don't need boundaries and you don't need disease definitions. And I think what it's all about is recognizing that poor people get sick, and sick people become poor if they weren't already, and that if we're going to do anything, that's where I think we have to start. Now, Canada and its Academy of Sciences has created an expert panel to report on Canada's commitment to global health. And the names of the committee, it's either Sarah Cherry and Prophet John is the member, and James Obizio. Very worthy people who have done a lot, and they said, in essence, wrong. They're not bad for having no leadership. And that in fact, when you talk about the barriers to Canada making an impact on global health, one of the key barriers is this absence of, from the top down, a commitment to doing something about global health and a coordinated attempt and a strategic plan for doing it. So they talk about how SIHA's commitment to global health is all over the map and it changes country. And in fact, SIHA isn't going to change where it sits. So it is a fair criticism. They did, however, say that there are some real key value adds. What is missing from the document is any kind of passion about a regret or a sense of indignation that we aren't doing more, that we have so much to do and to give that we are not addressing. Now, in order to take us from me and you and and they. I want to start with an image that I picked up a decade ago from Walter Kipp, and that is the global village. And I'm sure it's familiar to most of you that if one paused for a moment and thought about this globe of 7 billion people and reduced it to 100 in a little village, you would find about 57 Asians and about 21 Europeans and 14 from North and South America and 8 Africans, and they would be slightly more women than men. And the wealth of the entire village would be in the hands of 6 people, and they'd all be Americans. That may have changed a little bit in the last decade since I heard that story. 80% of them would have woefully inadequate housing, not to mention sanitation and water, and 70% of them would not read, and about 50% of them would be substantially malnourished. In fact, probably hungry. One would be on the verge of death, and probably due to a totally preventable disease, and one on the edge of birth, and probably at risk of a complicated birth because of no access. There would be one college educated among that 100 people, and no computers. That may have changed in a decade. Certainly there'd be cell phones. So if one pauses and tries to visualize this village, and I don't know about you, it's just not in my pen. I can't imagine how I'm going to relate to that group of people. I may want to desperately, I may want to connect and partner and do things together, but I haven't even been invited in. And I think I have to respect that this is unquestionably an extremely deeply rooted and storied community. It probably has unmet needs, but it has probably been very inventive in addressing those needs. And I'm not sure how they'd see me. And the last thing in the world they want to do is ask something of me. I mean, if I think about friendship, it takes me a long, long time to get to the point where I can actually ask for help. So I would like to suggest that in this establishment of a relationship, a partnership, that it really takes a lot of time and a lot of thought and a lot of visiting and back and forth and revelation of self and learning about others. And I would like to suggest that kind of partnership is something that takes if it goes to the institutional level, becomes extremely complicated. I mean, think about a one-on-one relationship that if you take it to the partnership level. Now, we've heard a couple of stories tonight that I think are extraordinary stories of partnership. Lori Lang talked about the partnership with Uganda in the Fort Portal area, and that is based on a 20, 30-year history of a personal relationship that was never abandoned. It was expanded and enriched and valued, and it had reciprocity, it was back and forth. The project, as they mentioned earlier, in maternal health with Ethiopia, I would like to suggest it's probably going to be an extremely valuable project, and I think it has gone incredibly well, partly because David lived in Ethiopia for a time, but probably more important than that was that Royal Alexandra Hospital, for over a decade, has had a strong partnership with St. Paul's Hospital in Addis Ababa, and has in fact exchanged visitors back and forth, has developed ophthalmology, has developed an emergency outreach, has provided antiretrovirals, has in fact created a real partnered relationship. And it seems to me that that's an incredibly important part of a partnership. It's that history and trust, and whether it's one-on-one or institution to institution. But let me just say to you that there's another layer of complication, and that is the funding. So, you guys are all aware that SIHA, the major aid agency in Canada, has just undergone a few hiccups, for lack of a better word. Oh, thank you. All nations have aid agencies, and there's a lot of debate about how they should operate. And in fact, there is an organization that evaluates these aid agencies, not just in terms of volume, but in terms of leadership from the very top, and in terms of coordination of policy and program and consistency. And SIHA scores not terribly well. And in fact, to illustrate what I think may be part of the problem is its minister, the Honorable Joe Fantino, has said that SIHA is important to Canadians. We would like some return on our investment. And so SIHA has moved into the Department of Foreign Affairs, which is not to negate the importance of aid. In fact, NORAD in Norway is one of the highest donor countries and one of the most highly regarded, and sits inside its Foreign Affairs Department. So that's not the issue. The issue is that at the very top, there has to be commitment and conviction. And I would submit to you, as a room full of global citizens, that we need to tell our leaders that we care about this, that we would actually like to show the flag in this very substantive way. In fact, Canadian aid, if you're just talking volume, has gone down from 0.3% of GDP to 0.25%, at a time when the UK has gone up to Lester Pearson's goal, our Lester Pearson's goal of 0.7% of GDP, during an economic crisis. So it's doable if we care about it. And I would submit that there is such a return on this kind of investment that we need to care about it, and we need to tell people that we care about it. Now, we can't blame our aid agencies. I mean, these issues are our responsibility. And there are principles on which this kind of aid is delivered in a responsible, respectable way. And the Istanbul principles have just been articulated over the last 2 or 3 years at the international level, and put at the root of all aid social justice and human rights and ownership in the hands of the low-income country member of the partnership. So that these, in association with gender equity and sustainable environment and transparency and accountability, all of these things matter. But the key is to recognize that at the focal point of all of the work that we do is based on the poorest of the poor having a chance to reach a level of access to care and to rights that all of us sitting here enjoy. Now, how does that apply to medical schools? Well, we've just heard from our dean, who has indicated his strong commitment to this endeavor. This is a hot ticket item. Of 150 medical schools in the United States now, there are over 100 programs. And Paul Farmer says a program is not necessarily something that is going to alter the lives of the poor. So that a program has to have at its root a clear goal and a clear link with the community in which that partnership exists in order to move forward toward outcomes. I would like to suggest to you that there are 4 steps in this process of getting toward global citizenship for global health. And the first one is the clause that examines the intent. Who are we? Where are we going? Why are we going there? And with whom are we going? And the second step, once self-knowledge is in place, is a determination for a partnership that is reciprocal. So that for every one of our students going someplace, one of their students has a chance to do the same sort of thing. And that doesn't negate, that's not going to attract people from low-income countries to careers in the north. This is going to create a partnership where we both have the same goals and intent. And I want to tell you a little experience that I had 4 or 5 years ago in the middle of the summer when a dean from the Philippines came to thank me for sending them a wonderful student for an international library. And at that time, there was very little oversight of where the students were going and why. And that dean said that that was such a nice student that she'd like to send us a couple of her students. And I just have to tell you that I talked a lot about how tough it was for us in our faculty of medicine, finding elective opportunities for our students. I talked a lot about how there wasn't really a slot for her student. And I just have to tell you, she was angry. And she left annoyed. I was simply not able to explain. And it was a strong lesson to me. It was how very presumptuous of me to think that we could just pat the head of the student on the way out the door to do their thing wherever they're going. And I would like to suggest that in all of what we do, we need to be thinking in terms of that reciprocity. It will always be variations on the thing, but always in this respect to acknowledge that we're not the ones that need this. So I'd like to mention 3 examples that stand out for me in terms of good partnership. And the first one one is the Making the Links program in Saskatchewan. And I mention it because in 08, when the medical students looked at all the global health programs in Canada, that was the one the students said was the best. And it's a program that begins by selecting applicant students on admission to medicine, and there are only 10 spots, and they are highly competed for. And it begins making the links with other right at home. And it does so in a couple of reserve communities in northern Saskatchewan and in a clinic called the Switch Clinic in Saskatchewan. And it then, with the same students who've taken 2 extra courses in addition to their course load, it then gives an opportunity to go to Mozambique, but not until they finish 6 months of Portuguese. And in fact, now that the program is so highly competed for that they've had double the number of seats, and they've added spots in Vietnam and in Nicaragua. And those students have to take Vietnamese and Spanish. So I mention that because the students see it as one of the best. And if you go to their website, you will get that feeling from it. The second mention I want to make, I'm going to be a little careful as I say this because I'm not sure if my facts are, but I want to mention the work of Dr. Clarence Guthrie, who was chair of the Department of Internal Medicine about 20 years ago, and then became president of Foothills Hospital, and maybe that's what sent him out of the faculty of medicine, I'm only guessing, but he had already done a little bit of international health. And his experiences at an international level were in Nepal, and then he was invited by a community in the southern part of the Philippines, a very rural, very poor community of about 3 million people who had the experience of seeing their doctors come from the city and go again. And so they had the lowest ratio of access to physicians in the country. And the community got together and said, let's create our own medical school. And they did it with a starting fund of $500. And with a conviction that if these students, local students, learned within the community, they would become committed to the community, and it has actually happened. There are 45 students a year graduated. They have improved the health outcomes enormously, and they have retained those physicians in the community. And Clarence Guthrie went back and got the first honorary degree they've ever had about 4 years ago. The second community he responded to was Lao. And Lao wanted exactly the same sort of thing, coming out of a 30-year period of no access to Western medicine. And some of the advocates for Western medicine wanted the big buildings and the big hospitals and the tech place, and others wanted community care. And what Clarence has told me is that he only goes where he's invited, and he only goes where he thinks he has the capacity to respond, and he no longer relies on SIHA to support that response because it's too complicated. And it takes him a long time to figure out before he does anything. He visits, and other faculty visit, and they come to visit Calgary. And by the way, Clarence has been sitting in Canmore for the last 20 years doing these remarkable things out of conviction that it is possible to do it, and probably, this is very heavy, more possible outside the institution than inside. Now, I'm only saying that, but I am absolutely. You won't think I'm Santa Claus anymore. is and what he's done, and he has, in fact, out of the conviction that you can partner with a community, live inside the country. And in fact, if you don't partner with the larger system, your efforts will be for naught. You absolutely have to be connected to the government and the government's plans. And what he does is believe that every patient he sees should get the same care his sister or his daughter or his wife did. And I've watched him on the phone, sweet-talking an orthopod in Miami into operating on a patient in Port-au-Prince and pulling money out of his own pocket to do it. It's a conviction that you don't settle for second best and that you can do it. And I mean, he's created Partners in Health, and it's a very, very well-funded organization that support from the Clinton Foundation, but they have never lost their principles. Their principles are that what matters is helping, partnering with the community, the individual, to help them walk out of poverty into a life where they have choices and options. So that's it. Nobody waved the flag at me that, sorry. So I would say that what we have to do is pause and reflect on who we are and what we're doing and why we're doing it and where we hope it will take us. We have to pause long enough to connect with our partners and trust them and make sure they have reason to trust us. We're not going away. We're breaking bread together for the long haul. And then we have to make a plan together, and we have to stick with that plan, come hell or high water, see the ups and downs, university top 20 by 2020. In spite of all of those things, we have to stick with our conviction that this is where we need to be and this is what's going to make a difference. And I think we can do it. That's it.